Hello everyone. So today we have a case of a 58-year-old gentleman who presented to us with complaints of dyspnea on minimal exertion. On examination, there was a 4/6 pan-systolic murmur. So you're looking at a parasternal long axis view of a transthoracic echocardiogram, and you see that the posterior mitral leaflet is prolapsing. Not just a prolapse, but the tip of it is pointing towards the left atrium, meaning there is a component of flail to this valve. Additionally, you see that both the mitral leaflets do not coap, so there is lack of coaptation between the anterior and posterior mitral leaflet, and this simply means that there would be regurgitation across this valve. So we take this case as an opportunity to understand, to recall that which scallops are visualized in certain standard views of a transthoracic echocardiogram. So in this case, you're looking at A2 and P2 component of the valve. This is a mode across mitral valve, and instead of appearing as a single line, the posterior one is hanging down, and that's how you see it in prolapse cases. So as expected, there is a regurgitation jet uh, through this through this coaptation defect. No significant aortic regurgitation. The left ventricle systolic function appears decent, preserved. So here, on a standard apical four-chamber view, you're looking at P1, A2, and A3 components of the valve. And in a standard two-chamber view, you're looking at P1, A2, and P3 components. So you have a large jet of mitral regurgitation, which is anteroseptally directed. So that's how you can predict actually. So if there is a prolapse of the posterior mitral leaflet, the jet direction is expected to be anteroseptally, and that's how you see it in this case. And in cases of anterior mitral leaflet prolapse or a flail or a ruptured cardi or a papillary muscle, the direction of the jet is inferolaterally. Some more views. So this is continuous wave Doppler across the mitral valve. So you see a dense jet, which is early peaking and triangular. So these features, if the jet is dense, early peaking, and triangular, suggest severe MR. So there is E-wave dominance on this mitral inflow pattern, and why there is E-dominance in cases of significant MR is because forward flow across the valve now includes the forward stroke volume as well as the regurgitant volume. Assessment of chamber sizes and function is important because that guides your management cases of MR. So you're looking at left ventricular internal diameter at end diastole and systole. You also calculate the effect on left atrium, and that's how you trace it. You don't include or go into the pulmonary veins or appendage, and in this case it's calculated to be 91, which is significantly enlarged. So once we have looked at the structural and the Doppler element of mitral regurgitation, we now would want to quantify it, and we begin with quantifying the regurgitant volume using the stroke volume method. So if you're given the mitral valve annular diameter NVDI, and then you have a competent valve LVOT in this case with its VTI and diameter given, you calculate the stroke volumes for both the regurgitant and competent valve, and then you subtract the competent valve stroke volume from the regurgitant valve stroke volume. So in this case, the stroke volume was of mitral valve was calculated to be 225 ml, and that of LVOT was 53. And subtracting both, you get a regurgitant volume of 172 ml in this case. And then you divide it by the stroke volume of the regurgitant valve. This gives you a regurgitant fraction of 76%. And then this is a measurement of Pisa radius, which is the proximal isovelocity surface area. You can actually calculate the effective regurgitant orifice area of the MR jet by Pisa method. That's another discussion. What are the limitations of this method in cases of MVPs or multiple jets? We're going to discuss those shortly. But for now, if you're given the radius of Pisa, the aliasing velocity, the PR Vmax velocity, the MR Vmax velocity, you can calculate the ERO by the formula 2 pi r square into aliasing velocity. So this is continuity principle actually, and then you divide it by the Vmax MR jet. That gives you ERO, and in this case it was calculated to be 0.47. So recall that an ERO of more than or equal to 40 or a regurgitant volume of 60 or a fraction 60 or greater, or a fraction of 50 or greater suggests severe MR. The limitations of PISA method in MVP include actually, so the ERO keeps on increasing throughout the systole. So you really have to measure the average systolic ERO. So you do that by taking the radius of the flow convergence at the level of the T wave, and then you take the maximal Vmax recorded. Another problem is that in MVP there is usually mid to late systolic MR. So you could still use the PISA method, but then you disregard the ERO, or and just consider the recurgent volume using the PISA method by the formula of multiplying ERO with MRVTI, and this gives you recurgent volume. MVPs usually have multiple jets, so you have to really go about each jet and calculate separately for each jet, which makes the process lengthy. So these are the limitations of PISA method in MVP. And then in cases of significant MR, you can observe increased gradients across the valve despite a decent valve size. So that's because in cases of MR, the peak pressure gradients are affected more than the mean gradient. It's also important to assess the effect of MR on pulmonary artery systolic pressures. You measure those by taking the peak TR jet velocity. So summarizing, there is a large jet which is occupying more than 50% of the left atrium. You have a regurgitant fraction of 76%, more than 50%, and a volume of more than 60 ml. You have an wave dominant pattern and a truncated triangular jet contour with early peaking. So all of these findings, along with structural element of a flail component, is actually indicating presence of severe MR. Thank you.